Hello, I'm Alon Barsom. Welcome to an episode of Global Innovations in Ophthalmology. It's my great pleasure today to be joined by Professor Farhad Hafezi from Zurich in Switzerland. Farhad, welcome.
Thank you for having me here.
I'd like to talk a little bit today about cross-linking. You've been very involved in the development and research. Can you tell us a little bit what we know now about cross-linking that is additional or different to what was first shown in the very first kind of Dresden Protocol cross-linking studies?
What we know now is fundamentally different from from the knowledge we had back in 2003 or 2004. I think nobody argues about the effect of a standard epi-off Dresden Protocol procedure. What we are trying to do now is evolving the technique, fine-tuning the technique, accelerating it, taking away the post-operative pain from the patient. But in this flood and sea of protocols, we have to be very careful, or the normal user has to be very careful to respect the properties of the cornea and not to get lost in these protocols. And this is where a simplification of the protocols would be highly useful. What is new is that soon after the Dresden Protocol came up, the idea of epi-on emerged. This was in 2009. This was Pinelli and Boxer-Wachler. And they simply took our Dresden Protocol that we had developed in Dresden and Zurich and said, let's leave the epithelium on, less infection risk. But to this day, none of the multiple modifications that were introduced into epi-on have given us a success rate that even comes close to epi-off success rates. There were attempts to bring in more riboflavin into the cornea by an active transport like iontophoresis, and the saturation levels are really high, and still the effect is bad. Which means that we realized, my research group in Switzerland realized in 2012 that there is probably more to cross-linking than only riboflavin and UV light. And there is another element that came up in 2010 or 11, which was again industry-driven, and they said, bigger, better, faster. Why do we need to spend half an hour in the OR if there is a law of photochemistry, the Bunsen-Roscoe law, that says we can do the same thing in a third of the time if we apply 3 times the intensity? They didn't mention that this was a mathematical law of photochemistry that has nothing to do with a living tissue and was never tested in the cornea. And we soon were confronted with devices that would promise what was never validated in clinical research. And so it took several years to prove industry wrong, showing that you cannot just freely accelerate the technique. And I mentioned epi-on now and accelerated techniques because they share one thing in common. It's the yet unknown factor that determines why epi-on does not work reliably yet and why epi-off works nicely with the 10 minutes 9 milliwatt setting, but a high acceleration gets questionable. It's oxygen. Our research group identified oxygen as an essential element in the biomechanics of the cornea. So we did very simple experiments in the presence and in the absence of oxygen, doing cross-linking in ex vivo human corneas under a plexiglass hood, and we flooded the hood with helium. And so we took down the oxygen content from 21%, like in this room, to 0.1%, tried to cross-link, and strictly nothing happened to biomechanics. And if you try to accelerate the treatment to a level where the oxygen diffusion into this tissue cannot keep up with the consumption by the cross-linking process, you will fail. And if you try to do an epi-on procedure, then you have an additional barrier, which is the epithelium. You can go back to old literature from the 70s showing you that the consumption of oxygen of the epithelium is 10 times the consumption of the stroma. So you have a huge barrier in front that takes away all the oxygen that is needed further down. And so epi-on, even if you have a lot of riboflavin inside, will not work because the oxygen diffusion barrier is given. So epi-on, we did a multi-centric prospective trial with Eberhard Spörl, one of the fathers of cross-linking, who spent a year modifying the riboflavin, and we had to stop the study for ethical reasons. We published the data, and we had a failure rate of 32%, as opposed to epi-off failure rate 3 to 7%. So in other words, it works, but the success rate is way down. The only instances I do epi-on personally is if I am really afraid of post-op complications like eye rubbing. So low compliance 8-year-old boy or a mentally challenged person, Down syndrome, because then I will live with a reduced success rate and I have a better control of post-op infection.
And what do you think? What do you think will be the key change or innovation in cross-linking that we may see in 5 to 10 years' time that is not currently in widespread practice? Can you think of 1 or 2 things that you think will be really different about cross-linking in terms of what's actually done or what's considered mainstream?
Done now. If once we accept that cross-linking is not a technique, it's a physiological principle of the cornea, then it's easier to understand why it diverges now into so many different fields. We have cross-linking for keratoconus, but we have the whole cross-linking in refractive laser surgery field, and we have cross-linking for infection, for infectious keratitis. And I personally believe that the biggest impact we can make in global ophthalmology is in infection, because antimicrobial resistance, antibiotic resistance will be a huge issue in the next 25 years. The WHO states that in 25 years more people will die from antibiotic resistance than by cancer and diabetes together. And the only reliable quinolone we have in ophthalmology, Vigamox, is a 4th generation quinolone. That sounds fancy, but it's a molecule that is almost 40 years old, and there is no new class of antibiotics. So we need to use cross-linking in areas that will give us a global impact, which I think is corneal infection.
Great. Thanks very much. Thank you for taking the time out of your busy schedule to visit with us.
Thank you for having me here.
This is Alon Barsam signing out for Global Innovations in Ophthalmology. Thanks very much for your attention.